In general, I don't like speaking at Target. Ever since I came to Target to speak about revalidation, Target brings me out in a cold sweat after the heckling I got then. But you'd be pleased to know that I'm speaking about something hugely popular today, the Health and Social Care Act of 2012. Right. The people you see sitting here in some way are part of the leadership of the CCG. And many of you who have been to the council meetings will already be familiar with lots of us around here. But I'm hoping that through the course of the presentation, you'll get to know people better, but also you'll be able to ask some questions of the people that are currently doing some of the work on our behalf. And also at the end of this presentation, we'll be opening the nominations to replace everybody sitting around the table, should you wish. And there's a letter on your table that is also going to come out from the LMC later this week detailing that. So the agenda for this presentation, I'm going to start with a basic introduction to Leeds North CCG. I know many of you around here will have been at council meetings or have had updates from your practice representative and will be familiar with a lot of this. But what we want to just do is ensure that at least a basic knowledge is there with everyone who's part of the clinical commissioning group. In order to be ready to take on statutory responsibility, we need to prove to the Department of Health and the SHA that we have built a robust organisation. And we will be assessed around several key domains. And these are the domains on here. So, domain 1, a strong clinical and professional focus which brings real added value. Meaningful engagement with patients, carers and their communities. Clear and credible plans. Proper constitutional and governance arrangements. Collaborative arrangements for commissioning. Great leaders who individually and collectively can make a real difference. Now, they sound straightforward, but as you can imagine, behind those titles, there's a hell of a lot of information and boxes that we need to tick, and actually good work that we need to do to evidence it. But on your piece of paper, around those key domains, there's a basic summary of what we've done to date. But this presentation is basically going to run through those domains, and then you'll have an understanding of what's on that piece of paper, and hopefully the clear and credible plan as well. Okay, so if you remember, towards the end of 2011, we had quite a difficult period in terms of deciding what constituted a clinical commissioning group. We'd all been affiliated, or most of us have been affiliated with various practice-based commissioning groups, and there were great degrees of involvement and definitely quite a lot of emotion at the time about which CCG you would subsequently be in. Through all sorts of arrangements which needed to be around local authority boundaries and wards and all sorts of things like that, we ended up in this negotiated position. So we are the pink area on the top, that's our geographical area, and our practices are the red dots. You will notice that there are some, you'll be able to identify your own practice, and some of you might be in a different coloured area, or there may be a practice that's a different colour in our area, but again, that was based on the proportion of patients who resided in the area that CCG was responsible for. I think one of the things that we'd really like people to really understand is how we are trying to develop the clinical commissioning group with a truly inclusive ethos. We really are trying to take forward those calibre principles that we had that really made people feel so engaged. And I'm just going to take you quickly through this diagram, actually, but there's a few key points that I want you just to go away with. So the CCG is made up of member practices. The core atom of a CCG is a practice. We have 31 practices, and as you know, each practice has both a clinical and managerial rep that represents those practices at our council meeting, which are every 2 months. And through Calibre and now into Leeds North CCG, those have been quite robust meetings. There's quite a lot of work that gets done there in the workshop element, and then there's a business element where there is discussion about some of the more tricky stuff that we're going to have to take on. And the majority of that discussion today has been around what we call micro-commissioning, so the sort of things that happen in a practice, like prescribing and referring. And you back at practices will have seen the outputs of that work. the work that you've been doing around peer review, the work that you've been doing around prescribing, the other work that's come out of some of the incentive schemes. But we are keen, going forward, that that body remains our main decision-making or informing body of the organisation. Now, that has some challenges, which we'll probably touch on a little bit later, as we move to something that's a statutory body that's responsible for a huge amount of public money. In between those meetings, we obviously need to function, and that council, or all of us as practices, need to be represented. And as we did with Calibre, we have a senior leadership team, and those are the people that are sitting here, and the majority of those posts are elected posts. So people apply, they're screened for competency in some way, and then it goes to a vote if the number of candidates exceeds the number of posts. And we'll be talking again about that in a short while. Now, going forward, previously that was enough for us. Going forward, as we move towards taking on a statutory duty, obviously there's legislation and governance, which means that we have to move towards having a board. But the function of our board is not there to make all the key decisions. The board is there to offer governance to our organisation and be accountable. Because when it comes down to it, we are trying to maintain the council as being our main decision-making body. There are other players in the city. So we have some providers across the city, and we've got three big ones that we have to be mindful of when we're contracting with them for the bigger commissioning things. So we've got Leeds Teaching Hospitals Trust, Leeds and York Partnership Foundation Trust, the Mental Health Trust, and Leeds Community Health, the community services. They're the three big contracts. We have to take responsibility and accountability for commissioning with them. And the way we have worked in Leeds and what we've developed is a collaborative structure. And again, we'll talk about that in a little bit further on in the presentation, but the three CCGs are going to work together collaboratively to manage all those big three contracts. We've been part of the wider structures that are forming in the city. So with the local authority, we've been looking at the Health and Wellbeing Board, Health Improvement Board. We're playing into the development of Health Watch, which is going to represent patients' best interests as well. But we also have our patient reference group, and you'll hear a little bit more about that later. And that is formed out of your patient reference groups that many have developed over previously or over the last year. So we do need to know a little bit about our population. We know about them as our individual practices, but something that's key in the Act is how we base our commissioning decisions. And we should be commissioning healthcare services based on need. And the information for that comes from the Joint Strategic Needs Assessment, which is just about to be refreshed. And that pulls together all sorts of data sources, and we can find out information about different segments of the population, by practice, by postcode, by housing, all sorts of things across the city. So that's going to be released later this month, but there's a few key points that are coming out about our population. So we know that our population, in terms of the CCG, being the smallest CCG in Leeds, is around 200,000 in terms of population, registered population. We have a roughly male-female equal split, but we do have our challenges in terms of tackling health inequalities, and that's evident in the JSNA. We have a 9-year mortality gap between those that are in the better off areas and those in the worse off areas. And that, in our area, over the last few years, that gap has not been getting smaller and in some instances getting bigger. We've had a notable population increase, 55% increase in the over 75s, and there's a 10% increase in the birth rate. Going on to the first domain, if you remember when we were Calibre, we sometimes had a reputation for not turning up to meetings across the city. And that's because we felt that if we send clinicians somewhere, or ask clinicians to go somewhere, it's very important that there's some value to it, because it's very easy to go to meetings and they just turn out to be a talking shop and nothing gets decided. And clinicians are an expensive resource. And therefore, we still work on the premise that if a clinician is going to be involved in a piece of work, they need to be there adding proper clinical value. And that is a premise. And we've been working on the principles around that and sharing some of that work with our colleagues across Leeds in the other CCGs. I've mentioned the structure of the organisation, and the members' council remains our key body where people will be able to bring issues, discuss them and have an output. The other main body, of course, will be our patient and carers group as well. And again, I mentioned about the clinical leadership team that will work between the council and the board. It's there in the middle to mediate, but it has to be operational. Again, we don't want a senior leadership team that just get together every couple of weeks and talk. It needs to be operational, and we're very keen on that, and we work to targets. We have what's called the Central Delivery Team, which is a group of people that look at key projects. So the work that you see around practices, so the prescribing incentive scheme, for instance, or some of the other engagement schemes that you see, or the incentive schemes, they are worked through this central delivery unit, and then the senior leadership team look at how they work. And they get lots of people feeding into that, but there's always opportunity for more people to be involved. And I want you to bear that in mind, that this is all our organisation, and there's opportunity to be involved if you've got a particular area of interest. We have Kath Johnson in the nurse position on the senior leadership team, and we see that nurses are central to making this work. We need a wider clinical team, and Kath's been doing an excellent job actually at trying to get nurses more involved, which is something we probably didn't do as well as we should have done originally, but I do feel that we're doing a lot better there now. I think as an example of what we've achieved within this domain is the prescribing, actually, because collectively, in terms of prescribing over the last year, in terms of money, and I hate talking about money because as clinicians we need to stay away from talking about money too much, and we need to be talking about quality, but actually these savings that are on here have been brought about by prescribing with better quality. And we've generated within our CCG over £1 million worth of savings that can be invested in other aspects of health. I'm going to just hand over now to John England, who has been acting as our interim lay member on the developing board, and he's going to talk a little bit about what's been going on with regard to engaging the voluntary charity and faith sector, but also our patients and carer groups.
Patients at the heart of everything we do. Strapline that we have picked up from ministerial speeches, it's in the white paper, it was there embodying a lot of the debate around the bill and now the act. But I think what we need to be doing and thinking about is how we turn a strapline into something that is extremely meaningful. And that has been the focus of my work over the last 12 months, working alongside the Calibre executive and leadership team. So we've embodied the sentiments of putting patients at the heart of everything in the vision and values of the organisation. It's there within the constitution, and we're starting to think about how it needs to influence our behaviours on a day-to-day basis. So we need to turn that catchphrase into something that's meaningful, and one of the steps that we've taken, an important step, is the development of a strategy, our patient and community involvement strategy. Patients have had an input into that strategy, and it's been to council. We've had a lot of comments back on the strategy, but it's meant to be a live document, and if you've not seen it, I would urge you to have a look at it and make your comments. In particular, look at our action plan and how we are looking to implement that strategy over the next 12 months. The focus there will be around building up capacity so that we can engage more widely with people in our community, the 200,000 people that we're serving. But there are different ways of doing that, and again, we'd like to have your contribution and views about how we might achieve that. Typically, when we bring patient groups together, the average age of the people who participate is probably 50 plus. Many of them have been attending patient-type groups over a number of years. And we're very conscious that if we're going to be engaging across the whole community, then we need to find ways of talking to young people, talking to working age people, talking to people who don't normally attend meetings. Some of you, through the practices and the development of practice reference groups, have started to develop the idea of virtual groups. There are other networks that patients are connected into, for example, Alzheimer's Disease Society, Stroke Association, and so on. The development of the practice reference groups, I think, is one of our priorities over the next 12 months. It's really encouraging that nearly all the practices within the clinical commissioning group have either well-established groups or are developing and establishing those groups currently as part of the DES programme. We're bringing those representatives together into our forum, the CCG-wide forum, which met this week. And those meetings can be quite difficult, but one of the things that really comes through to me is that we have got within our community and within our different practice groups a number of very well-informed people who want to get more involved in the work that we're doing. They are well-informed. They can be quite challenging. They've got ideas about how we should be commissioning services and working in partnership with patients. But if we can channel their energies and their commitment into doing things differently, then I think we've really got the opportunity to look afresh at some of the ways that services are commissioned and delivered. We want to build on networks that are already there. We don't want to reinvent wheels, reinvent structures. There's a lot that goes on in this city already, and we want to work through those existing networks and groups in order to engage with the wider community. And we've started that with conversations with the third sector organisations in the area. We had a very well-attended meeting with representatives of over 40 organisations quite recently. And it's surprising, and again, I wrote up the comments that were made at that meeting, it's surprising really that many of those organisations are keen to work with primary care, with commissioning, to really build different types of partnerships in the future. This desire for change, I think, is palpable, and we really need to capture that. And just finally, I'll want to focus really on practical opportunities for working in partnership with patients. I recently delivered a PPI session, patient public involvement session, at the clinical leadership training, and in the discussions that took place around tables, a number of good practice examples came out, and it became clear to me that in many practices this idea of working in partnership with patients around patient surveys and around the development of practice websites, just to highlight two examples, was starting to happen. Other people were saying, well, we're starting to think about other ways of working with our patients and working in partnership with them around services, around access to services and so on. So I'm quite clear that the people are beginning to think in different ways about how we work in partnership with patients. And really over the next 12 months, we want to build on that energy and start to explore new ways of working. Thank you.
I'm conscious of time, so I'm very quickly going to take you through the three domains and then pass over to Jason to take you through the last one. One of the things that we have to do is we have to make sure that we've got some clear and credible planning that goes on within the CCG to make sure that we're fit for the future. We've talked to you before about some of the ideas that we've had about how we commission services this year, but also we need to be clear about how we're going to service those for the future. Jason's already alluded to the fact that we've got quite a huge budget. It's about 225 million that the CCG is going to hold. So it's very much down to us as to how we use that money. And we'll need to discuss that with you. We'll need to make some savings. You'll have heard of this QUIP agenda that people talk about. It's the way in which we can think differently about the way in which services are provided, maybe more efficiently, maybe through greater integration, increasing innovation. And that's what their agenda is about. We have some ideas. We don't have all the answers. We're going to have to come back to you to discuss some of that with you. We will take the lead on certain contract areas. Jason's already alluded to that. The ones that we're going to take the contract lead in Leeds North are mental health, learning disabilities and urgent care. And I'm sure all of you will want to be involved in urgent care because that's the way in which primary care works predominantly when it's not in the 9-to-5 scenario. So in other words, the one-to-one, the out of hours. We'll want to have some great conversations with you about how that's going to work in the future. I also want to allude to the fact that we're not going to do this in isolation. We're going to have to do this with our colleagues. We will take a contract lead within an area, but at the same time we're going to have to work with the other 2 CCGs across the patch so that we work jointly from a commissioning perspective. In terms of what this plan's looking like, Jason's already alluded to this page that you've got on your tables. What we've tried to do is, we've got a plan, it's about this thick. We don't want to give all you that because at the end of the day you're not going to be able to read all that or understand it or have the time to do that. So a plan on a page hopefully gives you some idea about the headlines of what we're trying to do. We've talked about the role of the council of members. Absolutely crucial that we don't recreate another PCT. That's what you tell us you don't want us to do. So that's what we're endeavouring not to do. So the council will be absolutely the key decision-making group, being involved in those decisions, the empowerment at GP practice level. Now, at the same time, we will need to have a board. We will need to have that board for our statutory duties. The whole idea behind that is that we get the council and your representatives on that council to understand the core business and for those key decisions to be made there, and for that board to gain assurance from that council that those decisions are being made. And again, on your tables, just to reiterate, you've got the map that we're going to work towards. We need to make sure we don't have conflicts of interest on the board. We will have to declare those. We will have to do the same at the council, and we will be asking you to declare conflicts of interest in terms of council business. We need to make sure that we've got the appointment of the right people on the board to support that council. Jason's talked about that, and those papers are on your table. So we need to make sure that you've got the right people nominated through our member practices to engage in those decisions that we need to make. I've talked about the amount of money that we'll have. It's a significant amount of cash. That'll come through to them. We've delegated, we think, around June this year. Once we've got that, we need to make sure that we've got the robust financial standing instructions and orders in place to enable that money to be spent on behalf of the taxpayers whom we serve. Information governance needs to be there and needs to be robust to ensure that that can take place. And at the same time, the board needs to be assured about things like clinical risk, clinical outcomes, to make sure that we're providing a safe service for our patients. You'd be pleased to hear that we're not doing this 3 times in many ways across the city, that we're going to work with our other CCGs, and our other 2 CCGs are working with us on that. We've agreed a number of principles between ourselves. We will be a statutory body in our own right, as will be the other 2. But it's very important that we learn the lessons from the past and we don't recreate 5 PCTs. And a number of you will remember those 5 PCTs in the city, I'm sure, and the duplication of those. We can't afford to go down that route again, and therefore we need to think very differently about how they work. We've decided that there will be a clinical commissioning collaborative, and as a starter for 10, Jason's chairing that for the first 4 months. He's meeting every Tuesday. Key leaders from the 3 CCGs in the city come together for where we try to make collaborative decisions. That's particularly around how we can work together with some of the big contracts that we've alluded to, but also where we need to work jointly with the local authority. Many of you have been involved in discussions this afternoon about integration of services. I know the nursing groups have. And it's very clear that actually we're looking at integrated provision, but at the same time we can probably look to some degree at integrated commissioning, and that's what we need to be involved in from a different perspective in CCG land. And we've already said that we're going to take the lead in certain contract areas. At the same time, we'll be looking for certain clinicians to come forward to help us make some of those decisions within the CCG. Not just for our own CCG, but to give assurances to the other 2 CCGs that we are confident in our contract lead in those areas. So we are looking for clinical colleagues to be interested in mental health, learning disabilities, and urgent care, for example. And they're three of the people that we would really like to engage with in terms of taking our board forward. I've talked about the local working with the local authority and the importance of that being joined up. The other thing that we're trying to do is understand some of the financial risks. You'll be aware that across the city, pooled budgets have been arranged in certain areas before. So, for example, continuing care, learning disabilities. So we are working with our GP colleagues in other CCGs to agree financial risk sharing. We know that if one patient in a high-risk area hits one practice any one time, it can blow your budget before you've started. And therefore, where financial risk sharing with others or the pooling of those budgets seems to make sense, then we'll be working with them to ensure that that's the case. And then coming back to the council to make sure that that's agreed by the members. Now, at the same time, there are going to be changes in the way the management structures will work. Jason's talked about the board, and we will have that CCG board and the clinical team, with some managers being involved directly within that CCG, but not as per the PCT before. Some of those managerial support functions or back office functions will be shared at a higher level, at a commissioning support level, probably across the whole of West Yorkshire. And that is called a commissioning support organisation, a CSO. And what we need to do as a CCG is to make sure that we get the right service from them through a service level agreement, which the CCG will have to agree with the CSO. Sounds a bit complicated, but it can be worked through. Okay? I'm passing over to Jason now to finish off the presentation.
Okay, final domain now. Actually, I'm going to stand at this side because everyone's been standing at that side, so you've been getting neglected. Great leaders who individually and collectively can make a real difference. It's quite a grand title. But I'd like to show the work that we've been doing, actually, and it actually goes all the way through the organisation. And the reason I put this up is not just to show that as an organisation we're building up our skill and capacity, but it should offer you some reassurance that if you feel you have a skill gap that might be preventing you from coming forward to take part in this agenda, there's systems in place to help you get up to speed quite quickly. And part of this element is that I want you to be feeling reassured that if you did want to stand for some of the leadership positions or even get involved in some of the ad hoc work, then we can support that. So obviously we've had board level training. We're only starting to put together the board now. And hopefully over the next 2 months there will be a completion of most of those key positions on the board in terms of the formal recruitment process. Nigel, who's just been speaking, has been acting as our interim accountable officer. I think it's important to point out the difference between our CCG and some CCGs in the country. Some CCGs have opted for an accountable officer who is a GP. It's effectively your chief executive officer, your CEO. We felt very much when we went and spoke to the practices and definitely at council that the clinical chair model was more appropriate. And those people that need to make business decisions on a day-to-day basis, the accountable officer, chief executive, whatever you want to call them, should be someone that comes from a managerial background and have done that. We didn't think that was the place of a GP. And also in terms of succession planning, it would be very hard, I think, to find the types of GPs that would want to fulfil that role and take on that statutory responsibility. So we felt the clinical chair model was the one to go down, and so we do need to appoint our accountable officer in a more formal way over the next few months, and the processes are in place to do that. But at board level, as of that building up, there is a board development programme. All the senior leaders in the senior leadership team or in the board level training go on what's called the NHS Top Leaders Day. It's a scheme that's paid for by the NHS, and there's funding where people will be able to send out information about themselves to loads of colleagues, get some feedback around how they communicate, how they act in the leadership capacity. They do numerical skill testing and verbal skill testing, and then they go on a day of coaching, one-on-one coaching to actually work through what their development needs may be. And that's been quite a useful process, although most people are put off by it when they hear about it. But actually, if you get the opportunity to go on that for a day, it's definitely worthwhile thinking about. There's a recruitment process that we'll launch today does have 2 board positions that we are still looking to recruit to. Obviously, there were adverts already that went out a few weeks ago for 3 board positions. That was clinical chair, clinical director, and practice manager with board responsibility. 3 people came forward for each of those posts, and we were screened for competency and found competent, especially against the competition, and then put into place. But as part of the voting and selection process for this, practices and all the members of those practices will be asked to confirm that they're happy with those appointments in case you want us to go back and start looking again. But there will be an opportunity to ratify that decision through this appointments process. But 2 of the positions that are, we've got 2 GP non-executive directors, and effectively we are looking for 2 people whose skills are being GPs, people who understand our area and understand perhaps specific localities in our areas, if there's a specific area that we might want to have covered on the board. But those people do not need to feel they need any special skills other than the skills they have as a clinician. Any of the board competency stuff we can train people through. We all need to learn that anyway. Again, in the senior leadership team, people have again been on the top leaders programme or will be going on it. But there's also been quite a lot of development time to work out how we're going to run the CCG, looking at the model of business for the CCG. People who have been at the council will know that there's been quite a lot of development work that happens at the council, and there's been a lot of group work to help people understand things about commissioning and the commissioning cycle and some of the more complex aspects of how a commissioning body does business. And you'll also know that we've been asking quite a lot of those representatives over the last few months, because across the city we've been running a GP leadership programme so they can start exploring and building the skills to actually translate some of that information back to practice level so that the rest of the practices aren't excluded from that. And that will be a rolling programme, and we'll run it again for managers and GPs in the new year, so you can send someone else so you can spread that skill base and responsibility within the practice, because we know that there'll be different areas that different people want to get involved with. So there'll be more information about that. And of course, down at practice level, there's a lot of the work of the CCG in terms of the micro-commissioning that you've been doing already. And we need to help support that a little bit more through our educational programmes. But we're talking about systematic peer review that is now quite rife amongst most practices and almost normal practice. The engagement scheme asks specific things of you that do involve learning new skills sometimes. But we do have further development to do. When we look at this domain, the real skill is in this room. It's in our practices. It's the doctors, nurses, managers that work within our practices. And we really need to find a way to harness that more so people are involved in the work that's going on at CCG level. Because it is our organisation, it's a members' organisation, and we're coming together to share that responsibility and accountability. People have felt quite secure because there have been people in position in terms of the senior leadership team for some time, and they've built up a bit of knowledge about what's been going on, and fairly competently I think we've been carrying out the work that we need to pursue. But not all members of the current senior leadership team, for whatever reason, can continue going forward. So when we open these nominations, do not feel that you would be treading on anyone's toes. If you feel that you could do the job, put your name forward, because we'd really want to hear from you. So they will be open today, and again there's a letter in there that explains all that. Involvement doesn't necessarily mean you need to be part of the senior leadership team or the board. It doesn't even mean huge amounts of time. There are aspects of work that are clinically led across the city around the integration of health and social care, etc., that will need people's clinical involvement. And that can be nurse involvement, and it can be GP involvement, and sometimes managerial involvement. So I think it's worthwhile making sure that people do feel that they can speak up and be heard. And we're always looking for people to help us around various aspects of work. And as mentioned before, there are specific areas of interest that we really want to build up within our organisation, especially around our lead contract areas like mental health and learning disabilities, especially dementia, because dementia is an area that we really need to work on across the city. But the other area, of course, is education, and we would really like to find someone that would be liking to take on responsibility for organising, from a clinical perspective, not managerial, target, looking at how we form an education strategy. There's loads of things that we've been looking at to really develop the way that we can deliver education and focus it more on what practices want. But I'm very mindful that we don't want to hijack the education agenda from a political perspective. So it'd be really good if we get a clinician that's really interested in education to take that forward for us.